Good afternoon, members, and welcome to the Health and Wellbeing Board meeting being held today on Wednesday, the 4th of February 2026. My name is Sorrel Cooper, and I'm the new clerk to this board. As you're aware, the public element of today's meeting is being live streamed, and those participating in the meeting have given consent to their inclusion. The recording will be available on the City Corporation's YouTube channel following the meeting, and it shall be retained for up to 1 civic year. Chair.
Sorry, thank you. Thank you everybody for being here. We've got, as you can see, I mean, there's a mass of papers here today. I'm really sorry about the size of the pack, but we will try and keep to time and keep crunching through them. Where there are papers for information, I am going to assume that they've been read. On a couple of them, the officers will make short presentations and we will take some questions, but they are information only items. So I'd rather spend more time on discussion items than the information, if that's okay with people. If we run out of time, then we'll have to follow them up outside the meeting. So my apologies for that. So can we move that on then to apologies for absence, Sorrel?
Thank you, Chair. At item 1, we have apologies. I have received apologies from Marianne Fredericks and Gavin Steadman. I also note those that are observing this meeting online. Do members know of any other apologies?
I think we've also had apologies from Rachel Pye, who was coming on behalf of Gavin Steadman. So I don't think we've got anybody from Port and Environment and Health this afternoon, which is a bit of a shame because we've got some papers that are really quite relevant to them. So we'll have to see how far we can go. We may have to come back to some parts of those discussions. Can we then move on to declarations?
Yep.
Are there any? No.
Seeing none, we move to item 3. At item 3, we have the public minutes and non-public summary of the previous meeting held on the 19th of September. These are to agree on pages 5 to 10.
Okay. Any corrections or matters arising? I'll just quickly run through pages on your pack 5 and 6 and 7, 8 and 9, and 10. Seeing none, can we approve the minutes? Thank you.
Thank you. At item 4, we have the Better Care Fund 2025 to 2026 Quarter 2 Progress Report. This item is for decision on pages 11 to 24.
Ellie, I think you're presenting this.
Thank you. As noted, this is the Quarter 2 return for the Better Care Fund. We're required to bring these returns to Health and Wellbeing Board for their sign-off, and it contains a certain number of metrics which we have to aim for around things like hospital discharge, emergency admissions, and numbers of admissions to residential care. In Quarter 2, most of these were on track or actually slightly overperforming, like we'd improved performance on things like discharge. This is just for members' information, and to approve this, it's already been submitted subject to Health and Wellbeing Board approval. And just while I'm presenting this, to alert members to the fact that BCF is going to be very similar for the next year. We're waiting for the announcement of what has to be in the plans for the next financial year, but after that it will change, and members will be aware that there's a neighbourhood plan which is part of the new NHS plan and proposals, and the BCF will need to be part of that and align better with that. So there may well be some changes going forward on that.
Thanks very much, Ali. Members, any questions on this one? It is, whilst it feels as though we get reports on Better Care Fund quite regularly, it is important because it is a core part of some of our social care delivery. So we do need to give it due attention. Okay, Ellie, can I just raise a question that we did discuss a little bit in call over then, and you have referenced it, the change to the neighbourhood plan, and the concern that I have is that we don't get the same level of allocation into adult social care that we have had in the past through our own local arrangements. So could you just say a little bit about that,
Yeah.
so people are aware?
just for information and context, the Better Care Fund is a pooled budget, and within that, so it's money from us that we have to put in there, which is like social care, some social care grant, etc., and money from health. It has to go into this pooled budget, and then we decide between us what it's spent on. There's a minimum amount that has to be spent on out of hospital services, which basically comes to us and is what we spend within the BCF plan. That minimum is around 178,000, and that is, but we get more than that. We get 300 and something at the minute. So we do very well out of the pooled budget that supports our services and some of our delivery. I've checked for this next year, and there's no indication that ICB are going to change that or want more of that money back into health. Post that, in the new arrangements in the neighbourhood plan, we're not sure yet what's going to happen. We're waiting for guidance on that. It may be that they change the focus of the BCF to be slightly other things, but we wait to see what happens to that minimum payment then. But for now, ICB indications are that we won't be losing money in the BCF allocation this time.
Okay, well, this is a paper for decision, so if there are no other questions, we're happy to approve. Yeah, thank you very much.
At item 5, we have the Health Watch progress report. This is for information on pages 25 to 110.
Thanks very much. Gail, we've got a real bundle of papers now, and they're really important. And I know you weren't able to present last time, which is why there's so much this time. But we've got about 20 minutes for this item, so I hope that gives people time to ask some questions. But importantly, for you to present as well. It is an information report, but it is so important, I think, your findings, that we should take it quite seriously.
Thank you, Helen. And I think most of it speaks for itself. And I have to say, I was aghast when I saw how many pages we had. I think really it's to note the key things that have been going on in Health Watch. You'll see we did some work with minor injuries at St Bartholomew's Hospital. I think this is actually something we're going to be following up on with the team at the Royal London. Much underutilised service, and a lot we can do, and I think about how we promote its use, both for residents and non-residents. So I think and we're going to do a bit more work on this with the team at the Royal London, because that service is run by the Royal London. So we'll take questions, because you can see our report on that. And then we've also carried out our interim view at the Neiman practice, and that was and we've had a follow-up event, a launch and then a follow-up event with the practice, and lots of recommendations. And I do think we've made really good progress with the Neiman practice. I think it was very much partnership piece, and I think we've seen a real change in the way that we respond to them, they respond to us. I think it really feels very good. And of course we've got doing some work with them on their new triaging system, which there are some mixed views on, but I think on the whole it's been very positive. And we've included our interim view. We launched that at Barts, and I think at St Bartholomew's Hospital, and the big thing from this was that they have taken on board a lot of our recommendations. I think they found it really useful, and we had a really good launch where there was a lot of opportunity to ask questions about what they were doing in their future, their research and things. And I think that's really brought us much closer together with them, and I think helped them to kind of feel a bit more embedded in the community. But we had people from outside the City of London come, which is always good. As you can see, our next big project is St Leonard's Physiotherapy Department, where we've had a number of issues, particularly around the administration. That was struggling to get some traction, but thanks to Mary Elford, the chair of Homerton, we've been able to do that. I think there's an acknowledgement that there's some issues with the administration of that service, but lots going on there. So that's really, really good. And you can see that we've had a number of patient panels. The one patient panel I will really draw your attention to is the diet and nutrition session, where we put the slides up on our website. This was so well attended, and it was possibly the best session that most of us have ever been to on dietetics and nutrition. Really, really good. And I think if anyone else is thinking of running an event, the gentleman who did this for us was absolutely fantastic. We just had our men's health event yesterday, which was really, really well attended, and a great piece of work. Lots and lots going on in Port Soken, and we've been working really closely with Court of Common Councillors and with Deputy John Fletcher, and doing lots of engagement. And Rachel can talk about that more when people ask questions. And we're working really closely with other stakeholders who are, and particularly in public health. So it feels like a big piece of work that's been a long time getting off the ground, but is now really beginning to bear some fruit, which is really good. As you know, we've got the whole issue of where Health Watch sits and what is happening is still in the mix. We had a meeting with Department of Health, Social Care this morning, all chairs and chief execs from throughout England. Do I think we're any nearer anything? I think they're very focused on what's happening with NHS England, ICBs, but I think people haven't really thought through what does that mean for the patient voice. I think the big worry this morning, and Rachel can say what you thought, was that they have this director of patient experience and they haven't really thought through what the role is, and yet they're already the bill is going to come through in April, and they haven't really read the research, and they were very honest, to be fair, and I think really the role of Health Watch is the last. I get the impression it's not it isn't the most important thing that they have to think about, but of course patient engagement is the most important thing to think about if you're a patient or a user of social services. Other than that, we're continuing with some work on adult social care, which needs a bit more traction. We need to think about that a little bit differently. But I'd rather people ask us questions, to be honest.
Great, thank you very much, Gail. So questions from members first of all, and if not, I've got a couple that I can start off with, but Dawn.
Thank you for that. Regarding the Neiman practice, do we know whether residents and users have been informed of how to use the triage?
We've done quite a lot of publicity. It's been in a number, or it's been all over the socials. It's also been in City Matters. It's up on their website. We've run 2 or 3 events. So and they have also sent out lots of information. And of course, if you can't use it, they are very good at talking you through it and helping you. But there was actually, I think, a full-size piece we did a piece in Barbican Life and a couple of other magazines. I know I've seen. In fact, they've just photoshopped everything that has been up on the website or our website. So I think they've done as much as they can at this point. I mean, I find it, the first time I used it, I thought it was really difficult, but I think it's one of those things once you used it a couple of times, but they are exceptionally good about helping people and talking them through it.
Kerry and then Sarah.
Thank you. Thank you, Gail. Can I just ask, in terms of, there's a survey that you put out to assist with, I'm assuming, what demand there is and what people would want from the future. I'm just intrigued to see how much feedback you've had.
I don't know. Rachel would know the answer to that, I hope.
Yeah, unfortunately, we've only had about 4 responses so far.
Ah, okay. Do you want that shared then, perhaps? To
Yes,
try
please.
and get, okay, no problem.
Yes,
Thank
please.
you.
Thank you.
Sarah.
Hi, Gail. Thank you so much for this. I was just really struck by the juxtaposition between how much great work there is going on here, community engagement, scrutiny work, where there's real action as a result of it, and the uncertainty about the future. And I was just really curious. It may not be simply for you to answer. Ellie might want to say something about this, but what are you beginning to work on around how some of those functions might be fulfilled in future, even if Health Watch in its current form it doesn't exist, because it seems you continue to make the case for the importance of the work, and we've got growing uncertainty around it. So I just wondered if anybody could comment on how we're thinking about that.
Rachel was in the same meeting as me this morning with very senior civil servants. I don't think they know, to be honest. I don't know what you thought. It was kind of all a bit vague and woolly. I do. So they're expecting the ICB and the local authority to pick up basically whatever it is that we do. And they're not really, and what they're saying is it's up to them how they do that, and they might commission someone different, external. It's not. It felt like it's not our business how you do it. Here's the policy. How you do it is up to you. And I think for most of us in the room, that was not really very helpful. And I don't think they've really formulated their ideas. And I don't think anyone really thought through what No Health Watch meant. There was a lot of question about, well, how is health going to scrutinise itself? How will that work? And nobody really understood that. What would enter and view still exist? How can you go in and enter and view your own service? And I really don't think they've thought about how they're going to engage with the local communities. But they don't really see that. They see that as a detail. Here's policy, you implement it. Is that true, Rachel? That's what came across this morning.
Yeah, very much so.
Ellie?
Yeah, thank you. So we obviously very much value the work of Health Watch, and we've had good partnerships there and work well together. And obviously going forward, we don't know the exact detail of how it's going to work. And the scrutiny bit probably isn't going to carry on forward at a local level, but we'd be very keen to support some of the work of Health Watch going forward, perhaps through grants, etc. And I know we've got a meeting coming up with Simon to just try and work through some of those things that are really important, like the community engagement and your reach into the community, to really see how we could take forward some of the elements of Health Watch forward through grant funding. But yeah.
So
To say, really encouraging to hear that we're beginning to think about what we think is needed and how we might do it. And honestly, I really hear what you say, Gail, about there being a bit of a vacuum at the moment in terms of the guidance. But I guess the flip side of that is that it creates space for us to say, well, what do we want this to look like? So great that's where we're going with it. Thank you.
I think so. Just to follow up on, I think one of the things that was disappointing about this morning was that basically this is the policy and it's not up for discussion. But we kind of knew that anyway. So, but I do understand that behind the scenes there's a lot going on. It's not as simple as that. And it was interesting. And I think we have to be committed to working with Department of Health to make sure we get the best outcome for people. And that is rather than fight everything. And there is quite a lot of that going on, in the background as well. But I feel what we need to be thinking about is what is our ICB going to be doing? What are the corporation doing? And really keeping it local to us and shape that rather than, fight a fight that's maybe lost.
Thank you.
Go on.
Gail, can I just ask about the Bart's minor injuries unit, because that would be such a loss. I know I use it. I don't think many residents are perhaps aware that it even exists. I know schools are aware that it exists locally, but what can be done to save it?
I don't think it's in danger of going anywhere. I think but I think what happens is they cut their hours or they close it early because there's no one there. So they need to really advertise this much better, I think, and really, put it out there. We've given them some recommendations, particularly about the website and access. I think they need to take out a page in City Matters. They need to do a lot more. And when we spoke to the Neiman practice, they said, well, we always feel guilty if we send someone there. And actually, we're not going to feel guilty now. We can send more people there. And I think it's about getting that out there. So we write in Barbican Life, we're going to put in a piece about Barbican Life, put it back on Sway. And I think we'll help them, but it's kind of not our job to do their work. And it's kind of, so it's getting that balance right, isn't it? Between, so we will do things to support them and make sure we get the message out there. But I think they also need to do some stuff.
Yeah, thanks, Gail. I think that's right. I've only used it once, and when you manage to get seen by somebody, I mean, my experience was that the receptionist had obviously gone, and the hatch was shut, but a patient who was waiting said, "Open the hatch, put your hand down underneath the shelf, you'll find a phone, and then you can register." And so, you know, it was a bit bizarre, but you know, you shouldn't have to do that, really. But I do think that, I mean, advertising it, because a couple of times you've mentioned Barbican Light, which of course, when we live on the Barbican, we understand what that is, but we do need to make sure we get to all of the other residential areas as well. And I take your point on the minor injuries. It's not your job to be doing that, but it's making sure that people know that there are websites and communication systems across the city for residents, and to maximise our use of those, I think. There's a couple of other points I wanted to raise. The one, you've talked about the Portsoken community engagement and the health literacy work, and that's great to see that. But I did want to come back to 2 or 3 meetings ago. I think we asked for a piece of work looking at health inequalities across the city. And I know we're getting joint strategic needs assessment, but we were particularly interested and asked for focus on Portsoken, and particularly because some of the Portsoken members regularly raise what they perceive to be inequalities in Portsoken ward, and women and children in particular. So I'm piggybacking onto your comments here, Gail, as opposed to saying this is your job, but talking to public health more generally. We do want to see a report back on that, and we can talk about it more offline if needed, but it was a very clear, I think, request 2-3 meetings ago. I can't quite remember well. So if we can, please pull that together and schedule it in, Emmanuel, for a future meeting, please. The second one that I think you have been doing some work on, Gail, is defibrillators. And I know this is a bit of a vexed question, but regularly I get emails from residents saying what's happening about defibrillators, etc. And so I think that it would be helpful, and I think you have met with some of the residents who've been pushing this more. I guess I'm not clear how we draw it to a conclusion. We either are going to have more defibrillators, or we're not, or we're going to publicise what's around, just to kind of close it, because I think we need to be upfront and honest. If we can't do more, then we need to say we can't do more, but point people to where they can get more support and help.
The defibrillators have taken up some of our time, and we have met with people. Per head of population, of course, we have more defibrillators than anybody else in the country. Now, that doesn't mean to say they're all, all open 24/7, because they're not. And I think, but we do have 24/7 defibrillators. And we probably need to do more about advertising where they are, so that people know where they are. I think that's perhaps more important. Having more, where would you put them, and would they be accessible? I think the thing for me is about knowing how to use them, knowing where they are and how to use them, because a lot of people don't really want to use them. They're not, a lack of confidence. And then, so Rachel and I have talked quite a bit about this, about, how do we increase training for people in confidence generally, I think, in first aid in the city. I think the other thing with the defibrillators, and particularly out of hours, the police have a very good service. It's actually, they have a defibrillators in the back of their big 4 ones that tour the city at night, have defibrillators in the back of their, I'm going to say ambulance, but there's police car. And I think we probably need to really talk about what the service that we have on offer is, rather than what we don't have, and then look at those gaps. I think Rachel and I struggled a bit with what people really wanted. And I think it's because if you have 24/7 in every single block in Golden Lane, where are we going to put that? Where are we going to put it in Portsoken for residents? What is going to be open? And so we end up with the same problem that we've got now. And of course, the reason that we have one in the 3 towers in the Barbican is because they've got 24/7 porters, which makes it easy for access. And I know the porters do take them to other blocks. And actually, I was really heartened this week to see that the new defibrillators had arrived, and the porters were all doing their training and how to use it, and they were doing the online training and taking it really seriously. And I think that for me is more about how do we train people to be able to do it, and particularly if we've got concierges anywhere on the estate, any of the estates, have we got them suitably trained so they can support any resident in any crisis?
Kerry.
Can I just ask, do any of the defibrillators have the accessory, I don't know what the right word is, for the infants to be able to then use the defibrillator on infants? Because you have to use different size equipment, don't you?
Do you know, that's a good question. I think we will have to find the answer to that. I really don't know. I know the latest one that's arrived in Lauderdale is very fancy, so we'll ask them that. But I think that's a standard City of London one for estates. I don't think that we've got anything special. I think everybody's got the same thing.
Thank you. Yeah, might be something that whoever in the city deals with it. We need to. Thank you.
I'd like to kind of make a suggestion on this, because I kind of feel that we just keep batting it around and not really getting to a point where we can be quite definitive about what we can and can't do, or what we should or shouldn't do. So, Gail, you and Rachel have clearly done a lot of work on this, and I know that public health colleagues produced a paper with some data that provided some background to all of this. But I wonder if between public health, yourselves, and I think it's probably, I'm looking to Ellie, I'm not quite sure if Ellie's the right person, but can we try to pull together a single paper which just clearly sets out what we've got and how it can, how they can be accessed, and what we can, and be absolutely upfront about what we can and can't do more of. And just to close it, because I think residents will keep writing to us, they'll keep asking questions about it, and we just do keep going around the circle. So I'd like us to just find a way to close it. And if there's more ongoing work to be done, fine, let's be clear about it. If not, let's just close it. Right. Yeah, thanks very much indeed. And thanks very much, Gail and Rachel. Listen, really excellent work here. And I certainly hope that we can find a way to keep what has been really positive about your work in City Health Watch, so that we can continue to get this kind of level of feedback, because I don't think it comes from anywhere else. So thank you very much indeed. Okay, Town Clerk, can we move on?
At item 6, we have the City and Hackney Safeguarding Children Partnership Annual Report. This is for information on pages 111 to 272. Yeah.
Great. Just trying to find the right paper, 111. And Rory, you're here, great, to present. Let me just get to the right place. I was there all the time. Sorry about that. So this report in the city has been already to Safeguarding SEND subcommittee and to Community and Children's Services, and it's here today for information. Now, this is one I think where there is, a lot of important information in it, Rory. So if you could just draw our attention to the highlights, the headlines in it, if you like. We've got 10 minutes for this item, and then that should leave us some time for questions and follow up should people wish. Over to you.
Thank you, Helen. Okay, so high level overview of the report is the 24-25 reporting period. I think we would, as a partnership, be clear that good practice pivots on strong leadership, stable workforce, manageable workloads, and an appetite to learn. I think when you go through the annual report, and notwithstanding the fact that there are systemic pressures on all organisations at the moment, there's confidence that all of those measures, as they relate to the City of London, are sound. The pressures I kind of refer to, those link with budgets, they link with national reform and restructure, agendas, and case complexity as well. The key headlines for the City of London over 24-25, of course, the corporation had an outstanding rating from Ofsted as part of the inspection into children's services. Inspectors noting the significant difference that was being made in children's lives, so very positive. ongoing effective early help and care leaver offers, stable workforce, good improvements noted with colleagues in the police as well, with the strengthening of their public protection unit, continuing developments around Operation Make Safe that was being deployed to test the sufficiency of the response by hotels in response to child sexual exploitation, and their peel inspection that was published reasonably recently, resulting in 2 outstanding gradings and definitely a trajectory of improvement. And continued rigour and good interface with colleagues in education within the City of London. So overall, Chair, positive governance, strong leadership, no serious incident notifications. I think the things that we're alive to as a partnership at the moment, clearly there's the Families First reforms, partnership reforms that the City and colleagues are working through. Those might look slightly differently within the City's footprint compared to elsewhere, but nonetheless there's a focus. The changes in the ICB are clearly relevant, but across both the City of London and Hackney, and we are keen to establish exactly what those look like. I guess the recent announcement around police reforms is something that we'll be keeping our eye on, and how that might affect operations in the short, medium and long term. And I guess continued focus, as set out in the report, Chair, our testing of progress and impact as it relates to any lessons we've managed to establish through our reviews and auditing processes. Clearly, the kind of report speaks for itself. It goes into a lot more detail, but happy to take any questions.
Thanks very much, Rory. Any comments or questions from members? No. I mean, from my perspective, Rory, this is it's extremely comprehensive, and thank you for all of the work that goes into this. I mean, it really is significant. And I think also, just we've said this before, but to repeat our thanks to all of the officers in the city as and partners as well, because I think to have the outstanding, again, in children's services and an excellent report for SEND is a tribute to everybody who works on this. It's really, really good to see. I think it's fair to say, though, Judith, that there's nobody who's complacent about this. Sometimes if you've got those results, then the hard thing is to maintain it and keep your level keep working at that level all the way through. It's a tough call, but I think we do extremely well so far. Judith?
Yeah, no, thank you. I think it's always about partnership working and keeping the child at the centre of what we do. And I think that's one of the things that this partnership does well, to make sure that children and their families are at the heart of our work. So I think our partnership working is strong, and Rory's endorsed that. And that's what the difference is for the children in the city. Thank you. And in Hackney, of course.
Okay, well, thank you very much, Rory. We'll move on then to our next item.
At item 7, we have the City and Hackney Safeguarding Adults Board Annual Report. This is for information on pages 272 to 318.
Thanks, and welcome, Claire. I think this is your first report coming to us. You're very new to us, so good to see you. I appreciate that, having started partway through the year, some of this will not necessarily, you've inherited quite a lot of things, and you might want to say something about that. I don't know, but we've got about 10 minutes for this item. So presentation, draw our attention to things that you particularly want us to comment on, and then we'll have more general comments if people have. Thanks very much.
Thank you very much, Chair. Good afternoon, everybody. My name's Claire Solly, and as per the introduction, I'm the new independent chair with the City and Hackney Safeguarding Adult Board. So I commenced in the role in June last year, and I work 2 to 3 days a month across City and Hackney in this role. It's been a significant period of change, which has been alluded to for the Safeguarding Adult Board. So just want to take this opportunity really to thank the previous chair, who was here for around 10 years. So Dr. Lady Cooper, very generous and comprehensive handover to myself. So the successes and the achievements that you see in the annual report, which is published on our website, and hopefully people have had a chance to read ahead of today, they're attributed to Dr. Cooper's leadership, but also mirroring the Children's Partnership, a really, really impressive, strong collective energy and commitment and actions from partners across what really is an ever-increasing complex multi-agency system. So as an incoming chair, I've been really impressed with the energy across City and Hackney, the focus on City today, of course, for this board. So thank you to everybody who's contributed. I think it's really, really important. And one of the challenges as an independent chair is it's really important to keep that strong strategic oversight. But actually, I think it's really important and absolutely critical that we make sure that every action everybody takes across City of London, small, large, single, or as a multi-agency approach, really does have an impact on resident outcomes. And I think the annual report really showcases that in the quality and the meaningful case studies that are weaved throughout. So again, thank you to people who have provided those. It's an interesting position. So the annual report is 2024-25, and of course it won't be lost on the board this afternoon that we are moving towards the end of 25-26. We are beginning to draw up and plan for our annual report for next year, and I think it would be sensible to, where possible, be in a position where we can present that closer to the end of this financial year, if possible. The Safeguarding Board is a statutory board, multi-agency. The local authority is a lead with the other two partners of health and the police. I think it's really important just to outline what the purpose of a Safeguarding Board is. It's about prevention. So it's about preventing abuse and neglect, but getting that assurance that our multi-agency systems are effective and they keep the adults at the centre. That's absolutely critical. So from a City of London perspective, the number of safeguarding concerns that were raised in 24-25 mirror the previous year. The trend in relation to City of London has mirrored the national trends. So concerns rose from 2016-17, but they did begin to fall again in 2021. And there's lots of reasons that can happen around recording, around awareness raising, prevention, etc. The main types of focus in relation to the concerns for the last financial year were self-neglect. So we're seeing an increasing number, not unique to City of London, but nationally, in relation to the complexity of self-neglect of adults with care and support needs. And that is one of the key priorities of the Safeguarding Adult Board. Secondary to that was neglect, so neglect and acts of omission. And in joint third and fourth are financial abuse and physical abuse. A real strength in relation to the City of London data has been in relation to people being asked what they want to achieve. Now that may sound really basic and simple, but it can be particularly challenging and it can be missed. So 62% of people were asked their outcomes, and 69% of the people who were asked had their outcomes fully or partially met. Those numbers may seem slightly less than other comparable data sets from local authorities, but we have to bear in mind the numbers for City of London are smaller. So, what that equates to is less people in relation to the figure being smaller. What the data also tells us are that the people receiving concerns about are largely white men over 65. So it is representative of the demographics of City of London, but we are not complacent as a Safeguarding Adult Board, and we are continuing to challenge ourselves around seldom heard voices and reaching parts of our community that are not represented in our adult safeguarding data. The Safeguarding Adult Board has a really clear focus on reflection, on learning, and on continual improvement. So within this financial year, the board published 2 discretionary Safeguarding Adult reviews. And I stress the word discretionary. There's a statutory duty when somebody has died or has suffered serious harm due to abuse and neglect, and there's a concern of how agencies worked together. In those circumstances, we must carry out a safeguarding adult review. In the 2 published safeguarding adult reviews for JL and Steve, that statutory test wasn't fully met in relation to care and support needs. But I think that's something really positive in relation to the approach of the Safeguarding Adult Board, that it chose to do a discretionary SAR, so it places that real value on partnership learning. Some of the key learning that came out of those reviews was in relation to escalation policies, representation of housing, making sure people who were rough sleeping and homeless, there was equity around palliative care, awareness raising around mental capacity and self-neglect. So these are all key areas of focus that we look to in terms of the professional development of our workforce. And the report as well provides an overview of that professional development offer. As we move forward, we have a new strategy for 25-28, and that is detailed on our website. So we've got 6 key objectives. The 3 main areas of focus that we've decided that are the key priorities, so it doesn't mean we're not doing work in other areas, are around multiple exclusion homelessness, self-neglect, and financial abuse. Running through those themes are making safeguarding personal. So that's a term that basically means keeping the adult at the centre of absolutely everything, moving at a pace that's right for them. Equity, so equity in terms of accessing services, supports, etc., and mental capacity, so that human rights approach. There's things the board need to focus on, and as an incoming chair that I've recognised. So I think we really want to focus on making safeguarding everybody's business, making sure we're using the views of people across City of London and Hackney to understand their experiences of our response to safeguarding and using that in terms of our continual improvement. Being assured about our systems through data and also multi-agency audits, continual learning and development, and an effective multi-agency partnership. So again, with a children's colleague that's on the call today, community safety and the Health and Wellbeing Board. There's lots and lots of work that we have to do. There's real energy and engagement from key partners. Got regular meetings with Judith and Chris and yourself as lead member. City of London place adult safeguarding, I'm assured, as a key priority. The safeguarding audit complete by Adult Social Care demonstrates that, and that report is coming to the Safeguarding Adult Board in March. So I'm happy to finish there and happy to take any questions. Thank you.
Thanks very much, Claire. Very comprehensive summary of a very detailed report. So thank you. Members, any questions or comments? I think I saw Kerry first and then Dawn.
Thank you. Thank you, Claire. This was a great report, really interesting to read. So thank you. I can see you've obviously put a lot of work into it, or you and your team. Can I just ask, in terms of the numbers for the last 2 years being at 49, is that because it's the same people who have been referred, or are they all new cases?
Thank you for that question. It's a very, very good question. So the number, it is a coincidence, it's the same number. There will be repeat people within that data. I don't have the figure to hand today, but it's certainly something I can come back to you with. But there is likely to be people who are not only being referred once within the 49, and that's work that we want to focus on so that there aren't these repeats coming back.
Yeah, of course. Okay, thank you.
John and then Gail.
Thank you. My question is around financial abuse and just your views on whether you agree that it could be a two-way thing, because it could be actually the vulnerable person abusing a member of their family. Do you see that come up very often as well?
So there are
Yeah, sorry.
Oh, sorry, thank you for the question. There are particular complexities around adult safeguarding concerns, so abuse and neglect within the context of someone who is a carer and a cared for person, so someone who draws on care and support. So Our adult safeguarding duties also apply to carers. So I'm not sure if you mean a carer from a care agency or somebody who's a carer in someone's home that's a family member. Could I ask you to just
more so a family member, I'd say. Yeah.
Okay, thank you. So yeah, as I said, there's particular complexities and sensitivities. Yes, that does happen. And it's about how we approach that situation. So we really need to move away. And I have to say, I've been impressed in terms of the approach across City and Hackney in relation to making safeguarding personal, both for carers and people who draw on care and support. So it's not about safeguarding being seen as punitive and something that's done to people. It's about understanding the context and working with people at their pace to improve outcomes for them. And that's very, very difficult to provide a general response for because everyone's an individual. So it is approached with sensitivity and balance.
Thanks. Gail. Oh, sorry.
Yes, so me. Yeah.
Yes.
Right, thanks. Claire and I met a couple of weeks ago at a meeting, so I'm going to repeat one thing. But Claire and I did discuss about faith groups, because a lot of faith groups have a lot of safeguarding rules and policies and training and how they are included, because I think sometimes they won't contradict each other, they will be complementary, but how they're complementary isn't always easy to see. And I think if you belong to some of those groups, sometimes you feel I can only speak from a church background, it's the church's responsibility, and how does that integrate in with the general responsibility and the responsibility of the corporation. And I think there's that, I would imagine it's very similar in other faith groups. How do you not hold something in one group and not hold it in another? I think there's a bit more to do with faith groups, really. And then my second question, which you didn't really talk about, Claire, is about people who are self-funding and safeguarding issues and worries, because I think from some of my conversations with people, I think there's a kind of a feeling that if you're self-funding, well, you're not really, you can't be worried about safeguarding. That's all managed because you're paying for it, or you're paying for carers, or your family are managing that through private funding. And I think it's, how do we know who those people are, or how do we know if they're at risk? And I think I suppose, what is safeguarding really about? And it's not about interfering, it's about being supportive and helpful. And I think there is still a bit of a misunderstanding about that. Sorry, I'm looking at Claire there on my screen instead of all of you.
That's okay. Thank you. I'll take the questions in reverse order. So I think there's something about our community engagement plan, myth busting, to your point, what is adult safeguarding? So it's not about people coming in and taking over. It's not about people losing control. It's the complete opposite. People remain in complete control. They're clear about what they want to happen and what that looks like. Now, obviously, there's caveats to that. If people are under pressure, coercion, and there are others at risk, or there are concerns about someone's insight and understanding about those risks. But we're doing lots of work through our community engagement strategy to address those points about what is safeguarding, what are some of the barriers people are experiencing to recognising it and reporting it, and actually what happens thereafter. So we are focusing on that within that context. It doesn't matter if somebody's self-funding, is the short answer. They are, just as at risk of abuse and neglect as somebody who's a commissioned package of care. There are no differences at all. And I think it lends into our key objective in our strategic plan about safeguarding being everybody's business. So by doing that wide-ranging community engagement, awareness raising work, we need people to understand those key areas that I've just mentioned and have discussions with people and encourage referrals to the local authority. Now that has to be in the context of trust and all the key principles that I've just mentioned. So there is no difference in relation to self-funding. In terms of faith groups, so as the Safeguarding Adult Board, we are committed to engaging with everybody across the City and Hackney patches. So that includes faith organisations. And we've signed up to the London Multi-Agency Policies, Procedure, Practice Guidance. That's very clear in relation to the approach with faith groups, and we will work in accordance with that. We've just about to launch a key piece of work through an organisation called Global Manchester Foundation. So they're supporting us doing outreach and community connection with seldom heard voices in communities, and that will include faith groups. So understanding what that looks like, where those meetings should take place, on what day, at what time, and who needs to be present, and building those relationships with faith leaders to support us with the safeguarding agenda. So open, safe, transparent systems is the goal, which we have already across City and Hackney, but there's always work to do.
Thanks so much, Claire. Judith.
Yeah, I think as Claire's demonstrated, she's bringing a renewed focus on community engagement, and that's the real strength of the work she's doing and bringing to the partnerships and vital to our community, and particularly our bespoke community in the city. One of the additional aspects that we learned from a different survey was residents are feeling isolated. So our social care users are feeling isolated and lonely. And as a consequence, we've initiated a befriending service, and that was referred to in the health report. So that's an important step forward, because a lot of the issues people experience about self-neglect, being at home, risk of financial impropriety, can link from loneliness. So that's a really important preventative safeguarding. Our adult social care, since we mentioned inspection on the children's side, we're still awaiting the outcome of our TQC inspection of adult social care, which took place finished on the 31st of July. Notice how long that's taken. I will draw your attention to it. Thank you.
Yeah, thanks, Judith. It's very frustrating that we've not had that inspection outcome yet, but there's not a lot. I know we've been pushing. There's not much more we can do about that. We just have to wait another couple of weeks, I guess. I just had one question, and it might be more for Judith, I think, perhaps, and that's about the case reviews that are in here in the report. It's making sure that we maximise the learning and are clear about any actions that are relevant to us. So it's just seeking some assurance, really, particularly thinking about the links to housing and other services.
Yeah, absolutely. And one of the benefits we have as a City and Hackney partnership is that we learn from Hackney serious cases as well as City ones. So we always develop an action plan in response to any learning. We share it with staff, and we think about the implications. We can track that back and demonstrate that to you if that's helpful. Thank you.
Yeah, thank you very much. Okay, well, thank you very much indeed, Claire. It was an information item, but I think there's a lot of interest from members as well. So that's great, and look forward to the next annual report when you've very definitely got your feet under the table if you haven't already. But it sounds like you pretty much have. So thanks very much. Okay.
Thank you. Good afternoon. Thank you.
So shall we move on, Sorrel, please?
At item 8, we have the Adult Mental Health Joint Strategic Needs Assessment. This is for information on pages 319 to 452.
Thank you. And Jenny, I think you're going to talk to us about this one.
Yes, I can do a quick introduction. I do have some slides pulling out some of the main facts if that's helpful, but if time's short, really happy to introduce and assume everyone's read it.
I think if the slides are easily shown on screen, that would be that would be very helpful. We've got about 15-20 minutes for this item, so I think should be okay.
Right. I just because there's so much information, I did think pulling out a few things, but I'll try and be fairly quick. So thank you. I'm Jenny. I work in public health, and I have been working on mental health, hence writing this needs assessment. Although I should mention with huge support from our intelligence team, Tom and Marianne in particular, as well as providers, community, everyone contributing to it. So a huge piece of work, as you probably see. And you might see as well, just to pull out, we have tried to put in city specific information where we can, but sometimes due to the small numbers and confidentiality reasons, we can't always do that. But there is a city specific JSNA that's coming up, which we'll try and delve into more. So apologies where we haven't been able to do that, just to let you know from the start. And for anyone who doesn't know, a joint strategic assessment is essentially looking at the health needs of a population, in this case, mental health. So we've now got a good evidence base to help us understand and therefore take action on inequalities. And it can also be used to inform planning and commissioning decisions going forwards. This particular JSNA we've split into 3 parts. The first looks at the local population and the mental health needs there. The second, services and how well they're meeting those needs. And then the third summarises the challenges identified in the first 2, as well as making a set of recommendations. And those recommendations have been discussed and agreed with all key partners, so they're pretty robust. On the challenges I just mentioned, you'll see in the report there's quite an extensive list, but broadly they come under 4 main themes. The first being around difficulties people have accessing and navigating the services. One around inequalities. There is quite a lot of work that's happened in addressing inequalities, but more to be done in improving inclusivity, issues around getting and using the data, and then also some underlying accountability and governance issues for the mental health system as a whole. So just coming on to a few key facts that are from the report. There's loads more in there. I can't cover everything, but you'll see from these graphs that both for diagnosed depression and severe mental illness, the city is performing quite well with lower rates than London and England. However, the couple of things to pull out, one being that you'll see on the left-hand side, rates of depression, diagnosed depression are rising. We don't know fully how much this has increased awareness and acceptability, how much is increasing prevalence, but what it does mean is increased pressure on services. And then the other thing, this is an overall metric, but clearly within that there'll be pockets, different communities which will be more affected, and we are aware that that is an issue. So when within that inequality, apologies, I don't have these by City and Hackney, but I do understand the trends are pretty similar across both. So in terms of gender, anxiety and depression, which we call common mental health illness, which are the most common mental illnesses around, they're much higher in women. Interestingly, for SMI, severe mental illness, that's much higher in men. Age is quite interesting again. Depression most common in 40 to 74-year-olds. Anxiety much younger, peaking in 25 to 39-year-olds. And then SMI, it's highest in 50 to 64-year-olds locally. In terms of ethnicity, again, this varies, with anxiety and depression being highest in mixed white and black Caribbean groups, white British and white Irish ethnicities, whereas SMI is highest among black Caribbean and other non-African black ethnicities. Deprivation across all of them is highest in the most deprived communities. And then there's also a number of other population groups that we've picked out as being with having very high mental health needs, one being temporary accommodation, one being experienced rough sleeping, which is a big issue in the city, and there's a segment on that in the report. Gypsy and traveller communities, refugees and asylum seekers, and LGBTQI+ communities. So in the services report that I mentioned, the most of the data comes from these 4 services: East London Foundation Trust, City and Hackney Talking Therapies, the Wellbeing Network and Core Art. But absolutely, there are loads of community mental health services which play a huge role in the system, and really important. All the services do some prevention work, varying between them, but that's a big part in terms of the community. And it is also worth noting that mental health, as you probably know, spreads well beyond mental health services, and actually things like employment, housing, physical health services are all really important in terms of prevention for mental health. Outcomes. So for talking therapies, Wellbeing Network, Core Arts all have really positive outcomes when benchmarked against national and local comparators, and very high satisfaction rates. We don't have health data for that. And again, lots in terms of differences in service provision, but a few perhaps of the key points. So around gender, again, although rates are lower in for men overall, even taking that into account, they're still underrepresented in quite a lot of the services. However, in inpatients, they're overrepresented. For age and talking therapies, underrepresentation of the 45+ age groups, whereas Wellbeing Network and Core Arts tend to have an older cohort. For ethnicity, 88 African Caribbean heritage communities are overrepresented in inpatient, but underrepresented in their community services. For residents living in more deprived areas, they're underrepresented in both the Wellbeing Network and talking therapies, which is quite concerning because that's, as mentioned earlier, they have higher rates of deprivation anyway. And then for sexual orientation, we actually only have sufficient data from the Wellbeing Network for that, but broadly does reflect the local population, which is really positive. And I know a lot of work's been done there because that is a community which is often underrepresented in mental health services. Nearly there. And then in terms of patient client experience of accessing services, the average waiting time at the time of report, it does go up and down a bit. For the Wellbeing Network is 22 days, and it was 14 days of talking therapies. Have to know there is quite a lot of variation. I mean, in both services, it depends a little bit on the pathways and what specific services are waiting for. There's also quite high dropout rates from most of our large services. Don't know fully what's going on there, whether people are finding other ways of looking after their mental health, whether wait times are too long, who those communities are. So that's picked up in the recommendations. And then it is worth noting all the issues that are picked up, we do sort of tend to focus on what the challenges are, but actually it is worth saying that our mental health services are really valued, and they do a lot of really good work. But some of the things that have come up and been requested by residents and their representatives are, as I mentioned, easier to navigate system, services that are more inclusive. Again, work is being done, but more to be done. And for some people who have long-term support needs, it's not everyone, but for those that do, long-term support options can be limited. Also, it is quite talking therapies focused at the moment. Some people say it's too medicalized, and they want other mental health interventions that perhaps aren't talking therapies. And then also more in-reach and outreach work, which for addressing inequalities is particularly important. In terms of next steps, so we've just published this report and made the recommendations. I believe there will be an action plan and strategy coming. I'm actually moving away from mental health, and my wonderful colleagues Angela and Chris are taking over. So in terms of questions about what's coming, it will be them, but also that isn't really set out yet. That work's to be done, and I believe coming back at the end of the year. But so that is coming, but I'm really happy to take any questions on the report, and we can obviously take other questions but might not have answers just yet.
Thank you very much, Jenny. Any questions? Sarah?
Thank you so much for this. This was comprehensive and impressive and really clear. And I know you've just said the responses to this are sort of coming, they're on their way. But of course, that's where my head goes in amongst all of this, because the articulation of the problems is really clear. We've got actually really effective services when people use them, but some people feel they're not for them. Some people drop off either because they're annoyed with the referral system and they just can't navigate it, or because they're fed up of waiting. And we know that accountability is tricky because we're talking about lots of people working together. So how do we incentivize that? And these are really, they're big structural issues, aren't they? Like, how do we work together? How does this stuff fit together? And they're cultural issues too. What does it take to work collaboratively really well? And they're ones that I see up and down the country everywhere all of the time. So my question is, I know you don't have the answers to exactly what are we going to do about it, but how are we going to go about tackling these things? Because these are not simple, oh, we're just going to do this new thing and it's going to be fine questions. They're really quite deep questions to tackle, and ones where there is almost certainly learning to be taken from other people who are also doing that really hard work. So how are we going to go about tackling these really tricky and really important questions?
Jenny, just before you move into trying to answer that, there's a couple of points that we raised a little bit earlier today in call over. And in my mind, there's, I mean, as Sarah said, there is a huge amount of information in this, soft information, harder information, and that is really, really helpful. I guess that what there's a bit less, well, what there's not so much of is the service response to mental health problems in the range that's been described. And whilst we have very effective and very good mental health services, my question is really, and I've used the word of adequacy, but actually it's maybe sufficiency, because it's not a quality question, it's about a capacity question. You know, how short and are we of the level of service that we need to try and address it? And I'm not particularly interested, but I am interested to read the comments about homelessness and rough sleeping, because that is really significant in the City of London. And to see, I think you said 79% of people living who are homeless have a mental health problem of one sort or another, whether it's substance misuse or some other serious mental illness. And we know that housing is a significant problem in all of this mix as well. And so I suppose the question is maybe not one that you can answer, but maybe others in the room can have a stab at, is how we bring a really robust, coordinated response to this, drawing on all of the services and the range of things that we might have at our disposal, or identify where the critical shortfalls are in what we've got for our disposal. And one of the reasons for asking is, I mean, there's lots of discussions in the city at the moment about homelessness and rough sleeping and what we need to do next and how many new homes we should be building and where should they be. But I think it's also about the mental health is a clear objective area, priority area in City and Hackney neighbourhood plan and neighbourhood planning. And what does that mean for us in the city? And what does it mean for the level of service that we receive in the city? And I know that might all change with the NHS changes, but for us to keep that focus seems so important to me. You might want to have a stab at it. Then maybe it's Judith and Jed and others.
And I was taking a few notes, but my laptop's doing something, so I'll do my best. And if I forget something, please remind me. Sorry, caught in the moment. But yes, so in terms of responding, as I said, it is really hard to comment on that. And I think there's going to be layers of response because some things will be, like I mentioned, the dropout rates. I think that's something where further research is needed into understanding who's dropping out, why are they dropping out, and what's going on there, like whether it affects certain communities and so on. But then something that actually we can take action straight away. And I think that needs to be worked through. I know partners are all going to be working together, services and public health and NHS colleagues are all going to be working together on doing that. So hopefully that will include the service response and that joined up approach in that. And also, as you said, really important to pull in other partners from, because mental health, it goes beyond mental health and it goes into almost every other area. So it will try and pull in as much of that as possible. But I don't know if Angela or Chris want to expand on that because they're taking it forward. So I don't want to commit them to anything that they haven't already planned.
Can I just ask Gail to come in? I don't know if it's on the same sort of theme, Gail, before other people. No, it's something different. Okay, well, Jed or Judith, Ellie, do you want to come in on this?
I've got quite a lot to say.
Okay.
So I suppose to start off with, I mean, it's a really helpful report. So that's the starting point. It's really, really helpful. And it fleshes out a number of positives, because I think I'm trying to take a strength-based approach to my life these days. So a lot of positives in terms of kind of what's working well, etc., and a lot of the challenges, areas that we need to work on. So I just kind of flag some of the things in response to the challenges that are set out in the report. So data, starting with data. So I think one lesson to be learned from this exercise is how going forwards, and we're talking about doing an exercise that specifically focuses on the city, how going forward, so there's a clear set of arrangement, protocol, agreement in terms of how we maximize the amount of information that's shared. Because from an health point of view, we've got a lot of information, we need to share it, but without going to all the ins and outs of it, things, bureaucracy and other things get in the way sometimes of that. So there's something about how we share information. So we've got a complete picture and we review that information collectively on an ongoing basis. So there's that. There's a piece of work that we're doing with LBH and ICB colleagues around data completeness, which is another part of the picture, which is how do we make sure that the people who are receiving services, we've got as complete a picture of them from a demographics point of view as possible. So we really do understand kind of their characteristics and also in addition to that, their aspirations. So there is also something, as well as sharing information, there's something about how we have as complete a picture as possible. So a piece of work that we're doing will particularly focus on how we increase the capture of race, ethnicity, belief, because again, in the concept of City and Hackney, belief is quite an important area, which is not easily captured, certainly from an health point of view. So how do we capture that more effectively? Sexual orientation as well, and disability ability, because again, and that's both physical health and learning disability and also neurodevelopmental conditions. So there's something about how we capture that more effectively, and we've got a data completeness project on the stocks to actually do that. I mean, what would make more sense is not just us doing it in ELFT, us doing it as a collaborative project with others. So there's something around that. In relation, I mean, there's a lot of kind of bits, so I might actually do half of them and then stop. But in terms of outreach, I mean, again, it's a really valuable point that's been made in terms of actually quite often people who most need the support, who are greatest risk of deterioration, etc., are less likely to come and present themselves at services, particularly ELFT, where quite often there might be stigma, fear, etc. So one of the things we're doing with our community transformation, which I want to touch on a little bit, is we're categorizing clients into kind of three cohorts, and the third cohort is essentially those who are most in need, most at risk of deterioration, and there'll be a much more targeted approach, outreach, etc., to trying to meet those needs, assertive and intensive support, basically, for those. And some of that's come out of the Nottingham case as part of that. So there's specifically with our community transformation, what will be coming in is a much more clear focus on outreach as part of that. In terms of inclusive services, I think again from where I'm sitting in North, it's really important that one, we take responsibility to make sure we understand people's needs and aspirations, etc. But also we don't think we've got to function in a way where we don't act as if we think we've got all of the answers. So part of the whole response to inclusive services is, yes, we need to make sure there's skills and abilities and service design that actually meets people's needs in a more effective way. But it's also about how do we work with other partners, including voluntary community sector partners who might have better reach, better insight into communities. So that is a part of, again, what we're trying to do with our community transformation. The easy to navigate bit, which is the last bit I'll do for now, if that's okay. Again, community transformation, what we're doing, and as a proposition, I'm happy to come with more details of what that's going to look like at a time that suits. But part of that is we listen to feedback about people saying services are difficult to navigate. We don't really understand what service we're in. We're not sure who's supposed to be supporting us and what the actual terms of our engagement ought to be and what their offer is. So we're trying to make our services, community services, easier to navigate. Part of that is we're creating integrated neighbourhood teams in paired neighbourhoods, in paired quadrants, in paired neighbourhoods. So we will have, amongst other things, these specialist teams, including our specialist psychotherapy teams, integrated into neighbourhood teams or quadrant teams, so paired neighbourhoods. So the idea of that is effectively you've got one team that meets your needs, and as your needs change, fluctuate over time, you've got one team that will be wrapped around you. So hopefully that'll make things easier to navigate, because actually there'll be predominantly one team that responds to your needs as your needs change. Also, part of the challenge for us, and we want your support with this, is how we are much more physically present in areas. So for example, we had a conversation with a Neiman practice. Neiman is saying, we'd be happy to host your consultant psychiatrist some part of the week. We need to actually do the deal properly. Yeah. But part of this is about how we're much more physically present in localities as well. So that's kind of a taste of an ELF perspective on some of this. But I'll shut up now, but I've got other things I want to throw in later.
Okay. Are we still following the same theme? Because I'm conscious that Gail's patiently waiting. So, Sarah and Ellie.
Jed, that was super helpful. Thank you, and energizing. Just a couple of questions that build directly on that. So the integrated neighbourhood team piece of this puzzle feels absolutely critical. And my question is, what's included in that? Because of course there are clinical aspects to that. You've mentioned the importance of voluntary and community sector here. There's also the in my experience, the critical importance of peer support in those, but also some linked things around housing support, debt advice, a whole host of other things. So to what extent will that integrated neighbourhood team genuinely take account of the whole range of needs when people are presenting with mental ill health, but actually where the root of that might be something quite different and not clinical?
Yeah, really good question. So our starting point is to make sure that the ELF part of it is integrated. So that's the first part. So the clinical support that we provide, making sure that's integrated. But our clear aspiration is to build integrated teams that include, where possible and appropriate, voluntary and community sector partners. But also, again, we're mindful or conscious of the fact that treatment is, I think, 22% of what helps people in their lives. So we have to pay attention to the wider determinants. So it is about housing, financial support, etc. So I'm not going to say we've got a straightforward plan for that with all of that, but for example, we've got IPS services which support access to employment. So that's already within our portfolio. So that's part of what will be integrated. So we're starting off with what's already there in terms of the integrated offer, but our aspiration is to create as broad an integrated team as is possible with partners. The other thing that's probably worthwhile just throwing in quickly is also part of what we're trying to do, working with Chris, Angela and colleagues ultimately, is how do we create mini mental health systems in localities? So that, again, so we understand the totality of not just the health of the primary care of the voluntary community sector offer, etc. So we've got that local system that functions as well, which would support integrated teams.
Sorry, thank you. I think just on integrated neighbourhood teams, there's now a neighbourhood development group with partners where we're taking those ideas forward. I think for the city, we're going to have to think of something slightly different because some of our services are already integrated anyway, like social care, etc., some of the voluntary sector services. But we'll be working with teams like ELF to work out how that works in a bespoke way for the city, that we're not necessarily part of an or we're not our own integrated neighbourhood team, but we're part of. Or accessing different services from the integrated neighbourhood team, but we can keep you updated with how those developments are going from the neighbourhood development group.
Judith. Yeah, thank you, Jo. That's really exciting, and we'll be very keen to continue to be partners in that. We work well already together in terms of rough sleeping and those vulnerable people who need our support. We all know that rough sleeping is sometimes caused by mental health and substance misuse, and sometimes it's a causative factor. So you know, we understand the dynamics of that and work well on that. But there's always more to do. Thank you.
Yeah, no, I think that's absolutely right. And just before we move on this, I mean, I think that I don't know if other members share the same view. I'd be really interested to have something back here in 6-9 months, which, you know, I'm not quite sure when the right time is. We'll let Emmanuel kind of liaise on that, but I'd be really keen to keep keep not oversight, but to keep up to date with how this is progressing, because it just seems to me to be such a fundamental way of working and addressing this. And historically, not specifically to here, but tackling mental health just keeps falling through our fingers and we never quite grasp it. But this does sound really positive.
I was just thinking as well, could we not be involved as Health and Wellbeing Board in shaping it along the way as well? So not coming back in 9 months when it's sort of done and dusted, but if along the way we could be involved in helping shape that, that'd be really good.
Okay. Chris, and then I'm going to move on to Gail.
So thanks very much. And it's great to see the level of interest and enthusiasm. I think a lot of the work does need to take place at a local level. But also, I think with the ICB changes, there is going to be more work to try and unblock some of those blockers. So, you know, we haven't talked much about the data issues, but they're very, very well known. And we could try and solve this at the City and Hackney level, but it'd actually be much better if we solved it at North East London level. So some of these are likely to be in an action plan that's going to be, the priority is for us to address this, but actually the place it probably needs to take place is at the ICB level, and making sure that we do have, and I can see we've got quite a lot of our colleagues from the ICB on the course, making sure that that's prioritised as well. The joint strategic needs assessment that we're doing is giving us another opportunity to get some of the data and do some of this work. And absolutely, I was just a little bit worried that people weren't expecting us to come back in 6 months' time with a fully developed plan. What I hope we will have, because this is one of our priorities as Health and Wellbeing Board, is a number of opportunities to bring conversations here and also to invite members who are on this board to have those conversations with us outside as well, so that we do end up with something that you can look at and be really clear, this is what our local priority is for the Health and Wellbeing.
Yeah, thanks, Chris. I'm just processing a bit of what you said, because I think that 6 months is a long time and it's a short time, and you know it's a short time to really change things around and make it happen, but it's quite a long time to be clearer about the components and the direction of travel. So I think that Ellie's suggestion to keep working alongside each other to move us along is really important. Personally, I think to have a marker in the sand which says, you know, a report back on how it's progressing and at fixed points, because it keeps the focus in the mind and it keeps an expectation that things should be moving along. But I think, Jed, you wanted to come back, and then I am going to move on to Gail.
Yeah. trying to create a rod for my own back, but the sooner we can set out the proposed new model, the better, because we've gone through a process with partners of reshaping the community model.
Yeah.
So, and we're on the brink of trying to implement it. So I think the sooner we can propose it, set it out, say this is what we're proposing to implement, the better, because then there's that shared understanding of this is what we think it's going to look like. And then we've got the process over a period of time to, is it doing what we intended it to do? Is it working, etc. So I think setting it out sooner rather than later.
Okay, that, I mean, from my perspective, that's great. I didn't want to push if it wasn't ready, but I mean, liaise with Emmanuel, and as soon as you're ready to bring something back here, we would be very pleased to see it. Yeah, thanks. Gail, thank you for being so patient.
That's quite all right. My question is slightly different. When you were doing the needs assessment, I just wonder how much you explored people who perhaps aren't accessing mainstream healthcare or voluntary sector, but using apps and access to other kind of online facilities where we might not know what they're doing, and then how much you see going forward, how we might be using the digital solutions as well, so as we have greater access. And I accept that for some people that's not going to work.
So I'll start and people want to come in. In terms of digital solutions, we already have some available. A lot of those tend to be available nationally rather than locally, and it makes more sense on that patch. But I'm happy for to leave that up to colleagues to take forward if that's appropriate. That isn't something that we particularly picked up in the report or the recommendations, but can take that forward outside. In terms of the those people maybe not accessing services, we did talk to resident representatives and to sort of quite a lot of other support services that aren't mental health, in order to try and get an understanding of what these people might be. As you can probably imagine, trying to engage with people we don't know who they are is very, very difficult. So we did do it to an extent, and try to include that. Obviously, it's a very broad report, and we can't go into the same level of focus as we might. But it is in the recommendations as something that needs further work. So a bit of both, if that's okay.
Thanks. I do think it's something that needs to. I know there's a lot of national apps, but I think there is something around perhaps local support. Or I think there's some different things we can explore.
Right. Thanks, Gail. I mean, this has been a really interesting conversation, but I'm sorry, we're going to have to move on. But as we said, Jed, as soon as you feel ready to bring something back, then that would be great. But we've got a 6-month marker. If so, before that is brilliant. After that, we might push you a bit. Thanks. Okay, can we move on then?
At item 9, we have the update on progress towards heat and water stress climate adaptations actions in relation to health and wellbeing. This is for information on pages 453 to 462.
Okay, thanks very much. And Tim, I think you're going to present this, but it is an information, so we'll try and take it more or less as read, but do highlight a couple of things if you wish to. Members' questions after that.
Thank you, Chair. I'm Tim Monday. I'm the Lead Environmental Resilience Officer at the City of London Corporation. Since 2023, we've been working with colleagues in our public health team to bring a series of climate change and health related topic papers. So far, we've covered over heating and water stress. This paper really just sets out what it is that we've been doing since we brought those papers to you, covering in a bit more detail what the City Corporation is able to do and has done. So this has included looking at the overheating, increasing the number of cool spaces that we have registered with the Greater London Agents or Greater London Authority scheme, and running exercises for emergency responses. We're continuing to work as well on water stress, and we'll be taking a paper to policy and resources looking at what we can do to increase our water resilience, in a similar theme to what we discussed at the meeting in July 2025. I'm happy to take questions.
Thanks. Any questions? No. Can I just... Sorry, Gail,
I did have a question. Yes, I thought this was really interesting, actually, a whole new subject. But I think one thing I did want to pick up on is the water resilience. And there's a lot of developments in the City of London. How much are we thinking through that in the planning of water resilience?
Yes, it is something that we have specific planning policy on. It is a London-wide scale thing that we need to also be addressing. So a lot of the planning policy focuses on residential buildings. We have done some work that looks at what the water footprint is for the square mile. And actually it's through retrofit and new development that we can make our buildings more efficient. So one of the outcomes from that is actually we need to see more development in the city to be able to reduce down those water uses. Where we have increased pressure is actually where, as London continues to expand, particularly in its opportunity areas, that's where we really need to be ensuring that those places have the planning policy. So a lot of this work that we will be taking forward will be about coordinating how we work with our neighbouring authorities and more at a more regional level to ensure that we can minimise those risks.
Okay, thank you.
It was really helpful to see laid out what we mean when we say we're really working across the corporation to embed this. And sometimes that feels like it can be everything and nothing. So it was great to see that detail. Thank you. My question is just to double check that in your paper to P&R, one of the things they're considering there is the thing we talked about in July at this board, which is in the end having enough water is key to this, and that is about having more resources, and that's obviously a collective that part of what you're taking to?
Yes, it is. So certainly working, I sort of describe it as a bit, we're going to get our house in order first of all, but then using that as the opportunity to be able to working with others and to have that stronger call to advocate for more water resources, but also looking at, as part of that, how we control emerging new water demands, such as from data centres. As well as actually looking at our culture towards water, so how we think about it.
Yeah, I just got one other question, because it occurs to me that in a meeting last week we were talking about climate action, and Judith, you might be able to add if I've misremembered this, but I'm not sure that we were really talking about water and heat stress in that conversation in the way that we are through this paper and the next paper. And I just wonder how we are bringing these various pieces of work together, because it strikes me that we miss opportunities by not holding the whole, holding the ring on it all. I don't recall anything about heat in the climate action papers on Friday, Judith. Do you? Sorry if my memory is failing.
No, I don't think it was the core part of the agenda, but I think that you will be linked in with the climate action team. I'm looking, yeah, I'm seeing nods. So yeah, so I think that this is very much part of that, even though it wasn't necessarily top of the presentation. I suppose it doesn't necessarily hit as many buttons in terms of that particular conversation, but this is nonetheless a really important piece of work.
Yeah, maybe not, but I think if the paper's coming to P&R, perhaps if we could just leave it with you and talk to some of the climate action team colleagues to see if there's anything that's specifically relevant here that needs to be, if the two things come together in some way, rather than us having separate conversations in different places. That never feels terribly helpful to me.
If I can just add, so the climate action strategy has 4 objectives. 3 of them are focused on net zero, but the 4th one is about resilience. What we've done here is we've broken down a bit more about what we specifically mean about climate resilience. So Sam and the rest of my team, we work in the climate action strategy, so it is very much embedded and should be going forward as well.
Okay, so maybe we just didn't pick up and highlight that. I think. Okay, that's helpful. Thank you very much. Okay, well, thank you very much for the paper, and then we'll move on to health-driven. Sorry.
At item 10, we have climate-driven health risks paper on vectors and vector-borne diseases. This is on page 463 to 486.
So, Tim, you're doing this one as well? Sam.
Hi, I'm Sam Murphy. I'm Environmental Resilience Officer at the City of London Corporation. I'm also on one slide. And as Tim said previously, This is the next topic that we brought to the Health and Wellbeing Board, focusing on vectors and vector-borne diseases. This is one of the risks that we've identified as part of this climate action strategy, which is actually a sub-risk within our wider risk of pests and diseases. But we thought for the purpose of this paper, we'd focus more on vectors and vector-borne diseases, just to kind of highlight the interaction between the risk to human and public health and what we're currently doing in terms of habitat, environment, natural, and animal health. Yep.
Good afternoon, I'm Raz Chinyuki, Senior Public Health Specialist. I'll just give you an overview to vectors and vector-borne diseases and the associated implications for population health. So for background context, vectors are living organisms which carry and have the potential to transmit pathogens. So for example, looking at ticks and mosquitoes, they are very susceptible to temperature changes and therefore susceptible to climate. And notably, they account for 15% of all global infectious diseases. Most relevant to the UK include ticks and mosquitoes, which have the potential to transmit diseases such as Lyme disease, dengue, and Borrelia. They can reach us in a number of ways, including through our shores, transport, international trade, through our pets, and through migratory birds, as well as people returning from holiday. The climate change assessment has identified that we need to take more action in relation to vector-borne disease risk. And we've seen this risk materialize within the UK. So we detected some genetic material of the West Nile virus in the UK last year in May. And this has been accompanied by the movement of the tiger mosquito. If you look at the map over there, it's been migrating northward through Europe, and it's already been implicated in countries such as Italy, France, and Croatia, which have experienced routine outbreaks of dengue. In terms of the risk of establishment, climate modelling suggests that the area around London is already suitable for the establishment of the tiger mosquito, but the most of England and the rest of England will become suitable for its establishment by the 2040s or 2050s. This mosquito has actually been established and detected in motorway service station Overtrap situated in Kent in 2016, as well as an import distribution centre in the west of London. At present, our temperatures are too low to establish the West Nile virus transmission cycles, but it is anticipated that we may be incurring outbreaks in the southeast of England from the 2050s. And then lastly, with Lyme disease, this may increase due to an extended transmission season, as well as increased contact between humans and tick species. With respect to control and mitigation, it's quite important to understand that once a vector species has established within the UK, it is nearly impossible to eliminate. So because of this, the national policy on vectors and vector-borne diseases prioritizes suppression and control of vectors as being imperative and low-cost interventions. Though in the paper we've said that there aren't any financial implications with respect to our action, once a pathogen does establish within the vector population, for example, the cost and effort required for prevention as well as responding to human transmission will be very substantial. And this is because there's no existing immunity within the population if a new vector-borne disease is to be established. There will be also other accompanying costs, particularly impacting leisure, travel, as well as tourism. So the UK HSA leads on the National Contingency Plan for Invasive Mosquitoes, but and again, emphasizing this role of surveillance and control. Operationally, if any vectors are identified, the UK HSA implements a very aggressive approach. And this might include, for example, reducing the breeding sites, using any insecticides, promoting personal protection, as well as engaging with services that respond to these situations. For example, our health and social care partners.
So I think that we just wanted to give quite a high level overview of what we were already doing within the city corporation. So as part of the climate action strategy, we actually produced a horizon scanning report where we've kind of highlighted areas where we're already working on this. Obviously, this is a future and increasing risk, but it's already present amongst several teams across the corporation. So there are specific areas where this is more obviously it's a bigger issue. So in the natural environment division, as well as the port health and animal health services division. So there is a lot that we're doing. I think that the horizon scanning report kind of highlights that we are working on it in lots of areas, but we don't really have this joined up coordinated approach to this issue. The other thing that kind of came out of it was that there are lots of teams that are working on this. So we do feed into the UKHSA mosquito monitoring scheme, but it's been noted that, for example, it's not necessarily a core service function amongst those teams. So even though it is going to be something that might increase and need more future resources, it's not currently embedded in there and sort of in that business as usual approach already. So yeah, this paper really is, we've brought it, and we're kind of wanting to highlight that this there is a big interaction between the work that's going on and involving the environmental and animal side of this risk and health, as well as ultimately coming back to being a human and public health problem. Because obviously there are sides where about the establishment of it, but actually at the end of the day, it's the human risk that's going to be the big problem when that does become established. So really we wanted to, we brought forward this One Health approach, which I don't know if has come across the board before, but it is an internationally recognized approach used by the WHO. And it's basically showing, it's acknowledging the importance of the interaction between these three areas of habitat and animal and human health. And so I think we just kind of wanted to bring this and start this conversation and discussion and make sure that from a public health side that you are involved in shaping those future strategies or policies related to this across the corporation and organization, but as well as amongst partners too, because this isn't just a city corporation issue. However, there are obviously some actions relevant to the corporation and some for partners as well. So one thing we talked about is a biosecurity working group, but that's looking at working internally within the corporation to kind of align the work that's going on in lots of these different teams already. So I think that we're really happy to leave it there and answer any questions or open it for discussion. Thanks.
Thank you. Anybody want to raise anything? Sarah?
Just a quick question about where we've got any control in relation to prevention and also sort of response and mitigation, because it strikes me that when we spoke earlier in call over, Sandra made the really important point that there's a sort of global, national, regional, local partnership going on here. Like, to what extent do we in the city have any role in prevention, or is it simply about relying on really, really good prevention from the other players?
I think that, yeah, there is a lot of areas where this is quite out of our hands. You know, temperatures are going to increase, and ultimately there's very little that we can do within the city to stop that. We are obviously very vulnerable because of the aspects that Raz mentioned. Very dense area, there's lots of travel, high population, and we also are responsible as an organisation for a lot of open space within the southeast of England. So we do have responsibilities there to help that preventative side, but there is a lot on the response and resilience side of what we're going to do once this becomes established, if that is a sort of inevitable process. So there are different aspects to it within the sort of organisation as well as wider vulnerabilities, I guess. Yeah.
It strikes me listening to the presentation, and thank you very much, because I have to say this is something I've not really given very much thought to at all. So it's a really good prompt. And but it also occurs to me that there are a number of places in the corporation where this conversation needs to be happening. And I think you're suggesting that. And I think in the paper you do say that something will be going to Port and Environmental Health in due course. Because this paper is only listed to come here and not to other places. But I wonder if, I mean, it strikes me as though there's something that is really important, as you've just referenced, to all of the open spaces committees that we have. You know, I don't know how aware or familiar they are with any of this or if something similar is going to them. And of course, Port Health. And to look and the climate action proposals that we've been looking at kind of separate, as we've mentioned already, that it really needs pulling together. Now, is that in the biodiversity working group, or is it something else that's cross-departmental or cross-committee anyway, that, you know, we need to push that? Because and we're asked to agree to some recommendations, and then we're also asked to, I think, take an option. We've got option in addition to the recommendations, and we've got a long list of proposals as well on page 468 that we're being asked to, I think it says approve, and some of them are consider and advise. I mean, it seems to me that it's a yes to all of these, but it's not, we haven't got the powers in health and well-being to be able to deliver on these things. So we're saying yes, and therefore I guess recommending to others that who can act, do act. But how do we close or square that circle?
Yes, it's not something that has gone to any other committee yet. Like we said, we wanting to take it to Port Health and Environmental Services. There is a big open spaces. A lot of the work that's being done is already being done operationally within those teams, so they are very aware of this as an issue. They're probably less aware of that that we might describe it as a public health issue. So they're looking at it from a habitat point of view, or they might, they've come to us with issues around safety for their workers or visitors, where, for example, ticks is a problem in some of our open spaces, but they've not necessarily spread that with, okay, that could become a bit of a public health issue. So I think that what's useful bringing this here is that we get the endorsement of this board, that we can then take that forward and say, this is a public health issue, and that when we're shaping any future policy or working with those teams to add that training or providing guidance, that actually we can come back to you to either help shape that guidance and then share it. So I think that this is it's the first step in that process of going forward with those actions, but it's useful to acknowledge that this is very much relevant here, and being able to share that with those other committees or teams in the future.
Chris?
I mean, just an observation, because I think sometimes the papers which are well received then seem to go on a journey, but the actions don't always seem to then follow that journey. And I think you're right to say it's an issue of significance for the public's health. Sometimes when people say it's a public health issue, people then go, oh, that's for public health to then respond to. So I think what I might be hearing is that there's support for the, for the premise that we need to do something about this, and there's quite a lot as a corporation for us to do. And potentially this committee is then asking other committees to highlight what they can do to address issues around transmission, awareness, etc. Otherwise, I think there is a danger, as happens sometimes with other papers. They seem to go on a long journey, everybody nods, but nothing seems to then actually tangibly happen as a result.
Yeah, I think so. Raz, I think you were putting your hand up and down again. Microphone.
Apologies. The comments that Chris has made reflect what my opinions were. It was just a reflection and recognition that the transmission cycles impact everyone in different kind of ways. So, for example, when we consider green infrastructure and tree replacement strategies, there may be unintended consequences with that action that make it more habitable for some species of relevance. So it's just to have that horizon scanning and awareness of the risk and the potential future public health impact, and the shared collective responsibility that we all have in terms of surveillance and acting promptly when we do identify the potential for a vector species to be established.
Okay. Well, I think that if members are content with being asked to note the report and I think give active support on page 464 to receiving updates and supporting collaboration. And then, as it says on page 468, we're being asked to, I think, support option 2, using our influence. And then I think there's a long list there of that we're being asked to approve and actively support. Are we all content to do that? I think what I will do, I think, is like to just drop an email to the chairs of the other relevant committees, so the open spaces committees and Port and Environmental Health, to tell them we've had this conversation and that we're supportive of collaborative work across the corporation, and see what, you know, see whether, I mean, I suppose in my mind I'm wondering whether it'd be helpful for me to meet with those other chairs just to talk about how we feel that we can most helpfully contribute to this, rather than repeating work in various places. So would that be helpful or not to do that?
Yes, that would be very helpful and gratefully received.
Yeah. Okay, we'll do it. I'll do that then. Okay, great. So we've got a long list of approvals, and then we'll move on then.
Great. At item 11, we have the tobacco and vapes bill. This item is for information on pages 487 to 492.
Yeah, so we weren't going to have a presentation on this. It is simply for information. So any questions, please take up outside the meeting if you have. So moving on.
Thank you. At item 12, we have questions on matters relating to the work of the committee. I have not been informed of any questions in advance of the meeting. Do any members have any questions? Seeing none.
No.
Any other business that the chairman considers urgent?
I'm not aware of any. No. Okay, moving on then.
At item 14, we have exclusion of the public. Are members content to exclude the public for the remaining items of business? Okay, please allow me a moment to stop the recording.